These are my disclosures, and the other disclosure is this sort of sentence that you've read several iterations or several versions of this sentence said by other people in different ways and forms. And basically what it says is that whatever I'm going to say now, and everyone is going to say now, is probably outdated over the next 3 or 4 days, because there'll be new data and the present will be the past in just 2 or 3 days or 4 days by the end of the week. So basically the integrase inhibitors, they started some 10 or 15 years ago with Benchmark, which was the first trial to use Dolutegravir at a time that we're desperate for new drugs. These are people with triple class failure, and then there was this wonder drug where people we reached using Dolutegravir plus recycling drugs, reach 72% undetectability at 1 year. That was miraculous. And that started the age of integrase inhibitors. And now, as my predecessor said, we have 4 of these drugs in the market. And they are first line. These are the 5 most important guidelines in the world. I put 4 that you know very well. The 5th is Brazil, which is one of the most important in the world because I'm not biased, I'm Brazilian. So,
and also the number of patients in Brazil is
it's very large. Yeah. So Dolutegravir. Dolutegravir is the first one, and was the first trial was Dolutegravir versus the standard of care at that time, which was efavirenz, and the trial was head-to-head comparison. And at 48 weeks, it was a tie, virtual tie. It was I mean, you cannot say that one was better than the other. It was extended for 5 years, and at the end of 5 years, one could claim that Dolutegravir was superior to efavirenz, but that was a post hoc analysis. It was not was exploratory analysis, was not part of the trial, the the primary analysis. And there was a very large ACTG trial comparing Dolutegravir to the boosted PIs, which were first line at the time. And again, what they found was that when you use a composite endpoint of using virologic failure and tolerability, Dolutegravir was superior to either boosted PIs, in that case, darunavir or atazanavir boosted with ritonavir. But as mentioned, Dolutegravir had a major problem compared to other integrase inhibitors. It was twice a day, and the others once a day. So what they did, they tried to develop one Dolutegravir which was once a day. But mind you, this drug was done as expected. Twice a day was the same as once a day. But once a day is still 2 pills, and 2 very large pills. Because twice a day is 2 400 milligrams pills, 1 twice a day. Once a day is 2 600 milligrams pills. So these 2 big pills once a day that cannot be co-formulated. Virologically, the same effect. In terms of adverse events, the same. Doesn't matter how you slice it. They're very similar drugs, as expected. Then came Neovitegravir. When it appeared was, I love the name, the original name, which was known as the quad drug, because you could have 4 drugs in just 1 pill. And the main characteristic of the quad drug is the presence of cobicistat. Cobicistat is was supposed to be just a new form of ritonavir, a different ritonavir, which was a booster. And in fact, it's similar, but it's not the same, and that's quite important. And then it was tested against efavirenz, again, slightly better, equivalent in terms of statistically equivalent, slightly better, but there's a problem with the creatinine, and that was a problem. So Gilead developed a new form, as a formulation was mentioned before, or the so-called TAFT. And the idea of TAFT, they compared these 2 drugs, the new formulation of TAFT with the quad, with Tribuilt, the commercial name. And they found out that, however, it was better with the TAFT if you use not virologic endpoints, but everything else. And as expected, when you use renal parameters and bone parameters, the TAFT was better than the old TDF, and that's the reason it was developed. Then came Dolutegravir, and which was tested against Bigtegravir. And what you got, similar increases in baseline CD4. And I love this expression, non-inferior, which I really found horrible expression. Basically, they're the same. Being non-inferior, non-inferior, which is even more horrible. But then, when you look at side effects, both had discontinuations due to side effects, 2%, which to my mind is equal to 2%. But dolutegravir also had a small increase, was associated with a small increase in creatinine levels. And that's very important because there are physicians, and that's quite important in Brazil, some physicians that look at these increases as if they showed renal problems. They are not. When you start dolutegravir, there's a slight increase in creatinine levels, which may be up to 10%. And they occur early in treatment, they do not go up. They don't mean renal failure, renal insufficiency. It just means a blockade in creatinine secretion, which stabilizes thereafter. That's a very important point. But dolutegravir, which is supposed to be an extremely safe drug, then came a report at CROI 2016 from Amsterdam, in fact, a very high rate of discontinuation. 16% of people who started dolutegravir stopped, moved to another drug because of side effects. And then another cohort here, another analysis of another cohort in the Netherlands showed the same result. This result had a similar result, I believe, in Germany. We haven't seen that anywhere else in the world, as far as I know. I think the US never happened. In Brazil, never happened. So in Brazil, there's a very large observational study. It's less than 1% as in clinical trials. So we don't really know what's different in Amsterdam and in Germany. Maybe it's the dope you smoke here. Maybe it's genetic.
We call it co-medication. We don't call it dope.
Maybe it's the co-medication. Maybe it's genetic. I really don't know. Maybe there's some genetics involved. But the fact is that apart from Amsterdam and Berlin, the rest of the world is extremely well tolerated. So, I don't know. It's true, I'm being serious now. Everywhere else in the world is extremely well tolerated, but in Amsterdam and in Berlin.
Both Guido and the first and the last author will be here later today.
I know.
We can challenge them there.
No. But these are facts.
Sure.
Then came Bigtegravir. And that I'm not going to go into that resistance or the meaning of this slide, but basically to say that show that the Bigtegravir and Dolutegravir are considered to be second generation integrase inhibitors, basically because of the resistant patterns. And there are studies, obviously, comparing Bigtegravir to Dolutegravir, but in two studies, basically. But the difference between the studies is the background, the backbone that was used. And they're exactly the same virologically. But what they showed, in one study, was that Bigtegravir was, not this one, the other one I want to show is here, was better in terms of tolerability when abacavir was part of the backbone. So the problem is not that, to my mind, that Bigtegravir is better tolerated than Dolutegravir, but that the backbone makes a difference. And I'm sorry, I don't know if David is going to show these slides. When I looked at the program, I did not realize that David was going to be here. So I saw several of his slides, and I did not know if I don't know if he's going to present them. So, but basically, when you look at the integrase inhibitors, the major difference between them, one of the major differences, is the potential for drug-drug interactions. And they go from raltegravir, which is very low potential, to Neovitegravir, that's a very high potential, not because of the drug, but because of the booster. And these impact recreational drugs, as Charles called co-medications. And so maybe the co-medication used in this city might affect the tolerability of dolutegravir. And the problem when you look at the several drugs and several co-medications, the problem with the Neovitegravir as compared to the other drugs, again, is the booster. But one has to realize that cobicistat is not ritonavir. So when you're using a boosted PI and you move to Neovitegravir, you have to look again at the Liverpool site to see if you have to adjust whatever you're doing before ritonavir, because those adjustments are different. Because the two of them are boosters, but they boost differently. And again, although there are several co-medications over the counter that people use a lot, like antacids, multivitamins, iron supplements, these things are used the whole time. At least in my country, patients use it the whole time. People go to the gym, they use this a lot. And these are different. These might affect the absorption of these drugs, and they're not the same for each integrase inhibitor. People have to look at them and study which one you're taking, which supplement you're using. These are very important aspects, and they vary from integrase inhibitor to integrase inhibitor. And most importantly, the impact of integrase inhibitors on tuberculosis drugs, and that's extremely important for us in developing countries, is very, very different. To the point that you can only use dolutegravir and dolutegravir. These are the only two drugs that can be used to treat tuberculosis, even with rifabutin. There was a trial called REFLATE or REFLAT, I don't know exactly which one you prefer in French or in English, that compare efavirenz to dolutegravir twice a day, 400 milligrams or 800 milligrams. It was a phase 2 trial, relatively small, 50 individuals per arm, and people read it different ways. In some countries it was read that you can use 400 milligrams once a day of efavirenz. In some countries it was read that you needed to use 800 milligrams twice a day. But the bottom line is that dolutegravir became the drug that you can use to treat co-infected patients. Then came a trial using dolutegravir. And the important thing with this trial to note is that during the phase that the person is taking rifampicin, you use dolutegravir double dose, which is 50 milligram twice a day. The data so far presented is the data for 24 weeks. Very good data, extremely good, but it's 24 weeks. We're going to see the data for 48 weeks here at IIS. So at the moment, it seems that it'd be okay to use dolutegravir to treat co-infected patients, but I think, in my mind, we need to see the 48-week data. More than that, the REFLAT or REFLATE, they are doing a full phase 3 trial to show which is really the best dose, 400 or 800 BID of dolutegravir. The other problem is that there have been several reports of increased iris in patients using integrase inhibitor. Particularly, that's been attributed to the fact that, as you probably know, with integrase inhibitors, you have a very sharp drop in viral load. Viral load falls much more rapidly than with any other antiretroviral drug. So this is a very interesting study done in Africa. It's a very large trial. It's about 900 individuals per arm. Basically, naive individuals were treated, randomized to two groups. One started with the normal A-tripla. The other started with A-tripla plus dolutegravir for 12 weeks. And what we saw there is that although the viral load went down much more quickly in the dolutegravir arm, as expected, but at the end of 48 weeks, everything was the same. Mortality, undetectability, CD4, everything the same. And when they looked at iris, exactly the same in both arms. So in that very large trial, the use of dolutegravir, of integrase inhibitor, did not have an impact in iris in people with advanced HIV disease. in Africa, very large trial. The other very important point, which has a lot of bearing on the discussion that will be ongoing for the next at least several years on the use of Bigtegravir and Dolutegravir, is the problem of the backbone. All discussion between TDF and TAFT, now the TDF is generic. That's very important, at least for us in developing countries. They are similar, but they're not the same drug. TDF, TAFT, and that's a point that François was raising outside we were talking, TAFT reaches an extremely high concentration intracellularly. And we don't know exactly what are the consequences of that for pregnant women and other things. And it has lots of drug-drug interactions, which tenofovir does not have. More than that, I don't know how many of you saw, and I don't really know why it hasn't become popular. There was a very large meta-analysis published recently by Anton Hill, and I don't really understand meta-analysis, the methodology, so I don't really know if it was the correct methodology. But if the methodology was correct, that's a big if. And Andrew Hill is someone well known for doing proper analysis. So with that caveat, what he shows is that if you look at renal adverse events and you compare TAFT with TDF, TDF only has adverse events, renal adverse events, when used in conjunction with boosted PIs. If you use TDF without boosted PIs, without booster, you don't have renal side effects. The same applies to bone fractures. So you only have bone problems with TDF if the TDF is used in conjunction in a boosted regimen. To my mind, that has enormous implications for us in developing countries now that tenofovir has become generic, the lamivudine is generic. And the other point that I think is of enormous importance is the Swiss cohort. They looked at their data and they presented at CROI. Again, it doesn't show that well, but basically what it shows, believe me, is that they looked at a large number of individuals with no known important risk factors for coronary heart disease. These are very sophisticated imaging evaluation of the heart, and they showed that the presence of the bad plaques, or the ones that are non-calcified mixed plaques, the ones that are associated with bad outcome, cardiac outcome, they're associated with the use of abacavir. Not the use of any other antiretroviral. Just abacavir was associated with that sort of bad plaque. So these are the latest iteration of the HHS guidelines, comparing the 4 available integrase inhibitors. To my mind, as I said, these are the present ones, which will be outdated in 4 or 5 days. I think they will have a new iteration. They will have to have a new iteration after this conference. We have quite a lot of data, and I think there are lots of data to show, and I think some of these data will be discussed today. The pregnancy data, the data with children. There are several data that will be discussed today that I think, or this conference, that will change these guidelines and other guidelines. So in summary, the integrase inhibitors are widely recommended as the preferred third drug in first-line therapy. They're generally well tolerated, except for Dolutegravir in some European cohorts. As I said, I don't know the reason, maybe genetic, maybe co-medications. There are occasional reports of insomnia, depression, suicidal ideation, primarily in patients with a history of psychiatric illnesses, but these are reports. Emergent mutations, resistant mutations were discussed in the previous presentation. In addition to difference in resistance profile, as discussed before, integrase inhibitors differ considerably in potential drug-drug interactions that can have important clinical implications. I think this is a very important point when deciding which one to use. DDIs are extremely important. And again, DDIs are extremely important when choosing the backbone. I think they cannot be looked at, these drugs, in isolation. We have to look at them with the drugs that they're being used with. And with that, I thank the ones, that's something that I learned from Pedro, who's sitting there. You should thank the ones who gave you the slides, the ones who unknowingly gave you the slides, and that, as you said, if a thief that steals from a thief is not a thief. So, I don't know, I mean, we got slides from so many people that don't know whoever actually gave you these slides, whoever sold the slides, I just don't remember. So these are people whom I use slides. Thank you.